On our next session is a plenary session on the life course. And I would like to introduce the moderator for that session. Also, I just wanted to acknowledge that Dean Liu and I were together at UCLA when I was a PhD student. So it's wonderful to have him presenting in this panel. So our moderator is Professor Geeta Mishra from the School of Public Health at the University of Queensland, which is a new APRU member. She is an NHMRC Principal Research Fellow and Professor of Life Course Epidemiology at the School of Public Health at the University of Queensland. She directs the Australian Longitudinal Study on Women's Health, a major national study running since 1996 that has informed development of policy around women's health. She also leads a major international consortium called the Interlace Project on reproductive health and chronic disease. She is internationally recognized for her contributions to research on life course epidemiology and women's health. You could read her entire bio in the conference program, but we are very fortunate to have her and the two speakers for our plenary session on life course. Thank you.
Thank you, Melissa. Welcome everyone to the APRU Global Health Conference 2020 plenary session. The title is on life course. The conference is organized by Fudan University and the APRU Global Health Program. You heard Melissa say, I'm Geeta Mishra and I will be the moderator for this session. Now, please share the conference widely via social media. Details can be found in the chat function. The format of this session will be, there will be a 13 minutes presentation from each presenter, followed by a 10 minutes Q&A after presentations. So please do raise questions via the Q&A function during the presentations. Today we have two outstanding speakers. The first one is Dr. Wu Fan. You can read extensively about her biography in the program, but I'll briefly give an introduction. Dr. Wu is a chief physician, a doctoral supervisor, and the national expert with special allowance of the State Council. She's now the Deputy Dean of Shanghai Medical College, Fudan University. She's the President of Shanghai Preventive Medicine Association, the Director of WHO Collaborating Center for Healthy City. She also serves as the expert of Shanghai Municipal Leading Group for Control and Prevention of COVID-19, a member of the Committee of Shanghai Science and Technology Research Group, and a member of China WHO Joint Mission on COVID-19. Among her many achievements, Dr. Wu has successively served as the founding director of the National Center of Non-Communicable Disease Control and Prevention, China CDC. The title of her talk today is Elderly Care from a Life Course Perspective. So over to you, Professor Wu.
Okay, thank you, Chairman. Good morning, good afternoon, and good evening for all colleagues online and Insight. Today, I would like to talking about the life course healthcare for the elderly population. We know the world is getting old, not only doesn't matter in different kinds of countries, but all the countries that in the world is getting, the population is getting old. The speed is really quickly. China is getting older too. If we look at this parameter, and we found the old age population is getting older and older. So as well as Shanghai, the city that Fudan University was located. Also, it's a large city in China, but if we're talking about the area, it's a small city, but with large population, about nearly 25 million population, the residents, and also with a pretty high life expectancy to the end of last year. So Shanghai is even getting older. because not only the population, we have a large percentage of the old population, but also even in the old aged population, who above 80 years old, the percentage is getting larger and larger. If you look at the chart, you will find the 80 people above 80, the percentage getting more large in the with the years. So aging is gradually the public health problem, but the aging in itself, we normally we're talking about the aged population is a public health burden, but we don't think so, because all these aging process is going through our all life long. So what are we thinking about aging? Aging is represents a triumph of medical, social, and economic advance over diseases. Aging also brings about significant challenges. So nature, sometimes when we're talking about aging, we're talking about nature aging, but actually the aging is not only started with the people who have already 60 years old, but actually aging process already started when you are 25, 30, and or your 40s. So what do we talk when we're talking about aging? I think it is successful, sustainable aging is most important. It's totally depending on whether we have aging population, healthy aging population, or unhealthy aging population. So healthy aging, as the WHO gives the identification is it's a process of developing and maintaining a functional ability that enable well-being in old age. So we targeted healthy aging. This is really important. But what kind of effects that influence our healthy aging? If we look at these two parts, health conditions associated with aging have these disability, mental health issue, and variety and fall, etc., and of course NCD. And the other factors influence healthy aging, also genetic, environmental, and behavioral risk factors, and socioeconomic status. So what we want to know, what kind of influence really have the contribution on healthy aging in China and in the developing countries. So WHO, we take part in the SAGE program launched by WHO, and we also have different kind of 3 waves survey already have. This is the 6 countries, and we also have 8 sites, 8 provinces, 16 sites joining our program, and we got the general understanding of what kind of a situation that we have regarding our healthy aging. So here I give you about the different kind of chronic conditions. So you can see a lot with the age going on, the age group going on, and people have a lot of different kind of chronic conditions, and even they have not more than one chronic conditions, even have 4 plus chronic conditions already. So this is chronic condition is main problem. The second is disability. Of course, we're using ADL to measuring different kind of disability level, and we will see with the age group going on, the age group over 80s is extremely have the ADL, the really have the ADL, the not very good. They have difficulties, serious difficulties in that age. And the variety also, here I'll give you a look at the picture, this 6 countries, and China is not, although China is not worse if we compare with 6 countries, but China still have a big problem of variety. Cognition is another problem that here I give you the charts as we compare wave 1, SAGE wave 1 and wave 2. They have the same group, same population, and we'll compare with them about the cognition performance. And we found with the age going up, the cognition performance decreased very quickly. And also this is about 5 years later, we have the wave 1. So here, there's the main. Due to the time, I didn't want to go to detail. So healthy aging is the target, is the goal that we would like to have. Shanghai is already have the aging population since in the middle 97 days. And until now, Shanghai is even going on aging population, have a more percentage. So how we make a healthy aging in Shanghai is important. So we organize in different domain. One is the organizational structure, to complete the organizational structure to give the fully support for healthy aging. And the other one is healthy policies, and also prevention is more important. We prevent the NCDs and also prevent risk factors, and also offer long-term care system for the elderly people. Here I would like to give some case of what kind of program that we are going on right now in Shanghai. Healthy planning action plan. This we just issued last year by the government, and it's quite have a lot of domain, and it's including one of the healthy aging and also promoting healthy lifestyles, have mainly targeted in prevention issues, but also we have a lot of these, including the long-term care system development. Smoking, banning smoking, we issued this, started since the year of 2017, and we 100% of the public health places banning smoking. That is the case of policies making, and we also have the organizational structure, especially the health system, to support the healthy aging, do prevention, do long-term care, and also do offer the diseases management services. So this is the national structure, management structure. If we look at the bottom, the blue line, you will see that is the community healthcare center. It's most important, the bottom line. We have very complete primary healthcare center that in Shanghai built to deliver all these services to individual, to the residents. This is the picture showed you about the lifelong health management in Shanghai, from birth registry to death registry. In the middle is risk factor surveillance and intervention, include the use and behavioral risk factor surveillance, twin study, twin registry, to look at the gene and gene environmental and health, the relationship, and also early detection of certain NCDs, and also the disease registry, and also offer disease management. If you look at this, the bottom line is also we have the aging and the health study, and not only on this, we also have the diet and also health status surveillance going on over the years, for many years. I will give you some cases that what we do in Shanghai. Early detection is very important. We do surveillance. We started this surveillance every 2 years, and we go cross-sectional survey to getting the main data from the about the population. And these surveillance, we also combining some disease intervention. Here, there's the many diabetes intervention. If you look at, we not only treat the patient, give the patient health management in the community, in the hospital, but also we targeted on the high-risk population, even the pre-patient, especially we try focus on these using the data that we have already on the risk of, on the history, family history, behavioral risk factors, and we're also measuring some blood glucose, and we targeted this intervention in very early stage to prevent them develop as the latent patients. So these program we started in Shanghai over 10 years. And the other one is we started a free colon cancer screen program. Okay, so this is, if we compare before we started in the year of 2009, we found we have totally different large differences between Shanghai and the US, the early stage, the rate of colon cancer. Then we start the free screening program, and you found it is really, really effective that we amount among the population. This is, we also, this free pneumonia vaccine for adult people. This one is very important, especially this year on the background of COVID-19 outbreak. And this is actually, we started the year of 2013, and already we have a 1.5 million doses already done. And this targeted older people over 6 days living in this city. And the long-term care, I give a case, we give the offer long-term care in this city to elderly people. We also do evaluation depending on different, stratify into different kind of level, depending on their diseases, severe, and the ADL, cognition, vision, and hearing, and also domestic socioeconomic status. We do evaluation for them and offer them different kind of grounded long-term care. This is before nursing house, and we can see the lower need, and we stratify the different kind of level, especially the high need of long-term care, and we will offer that is community-based long-term care system that we build in Shanghai. So for summary, I would like to say people are living longer, it's true, and we hope people live longer, but we hope not only they living longer, but we're also hoping them living more healthy. So aging population could be a burden, but it also could be a treasure for the society, because healthy aging would be a really good, we think it's resources for the society. So let's do our best for targeting at healthy aging and a healthy city. Thank you.
Thank you, Dr. Wu, for that inspiring talk. I'd like to introduce our next speaker, Dean Michael Liu. Dr. Michael Liu possesses decades of expertise in maternal and child health policy. He's currently Dean of the School of Public Health at the University of California in Berkeley. Dr. Liu served as the director of the Federal Maternal and Child Health Bureau under the Obama administration. During his tenure, he transformed key federal programs in maternal and child health and launched a major initiative to reduce maternal, infant, and child mortality across the nation. He oversaw the launch and expansion of the federal maternal, infant, and early childhood home visiting programs. For his leadership, he was awarded the prestigious U.S. Department of Health and Human Services Hubert A. Humphrey Services to America Award in 2013. Today, he's going to talk to us on improving global health, a life course perspective. So over to you, Dr. Liu.
Thank you, Dr. Mishra. Can you hear me okay?
Yes.
I'll go ahead and share my slides. And can you see my slides okay, Dr. Mishra?
Yes.
All right, so what does the life course perspective tell us about improving global health? This is a question that I've been thinking a lot about over the last 20 years. And I want to thank APRU for this opportunity to talk with you about it today. I've been thinking a lot about it from the context of maternal child health disparities in the United States. Despite being one of the richest nations on earth, the US continues to have perhaps the highest maternal and infant mortality rates amongst developed nations. Moreover, we continue to have these large disparities. Today African-American women are still more than 3 times as likely to die in pregnancy and childbirth as a white woman, and an African-American baby is still more than twice as likely to die within the first year of life as a white baby. And that's a gap that we haven't been able to close in decades. Now, for a very long time, we thought that this was all about prenatal care. In fact, it was really promoted by a landmark study by the Institute of Medicine back in 1985, which found that women who had late or no prenatal care were more likely to have low birth weight babies, and therefore it recommended that increasing universal access to prenatal care needs to become a cornerstone of our national policy for reducing low birth weight and infant mortality. And after that, the federal government and state governments followed suit and vastly expanded health coverage for prenatal care, especially for poor women. And that led to a significant increase in prenatal care utilization, but unfortunately, not a significant decline in low birth weight or infant mortality. Then in 2003, my colleague Neil Halfon and I wrote this paper that called into question whether prenatal care may do too little, too late to truly improve birth outcomes. And we made our argument based on the life course perspective, which views pregnancy outcomes really not as the end product of the 9 months of pregnancy, but as the entire life course of the woman leading up to the pregnancy. Disparities in birth outcomes, therefore, are the consequences of not only differential exposures during pregnancy, but differential health trajectories across the life course. Which means that if we really want to do something about improving pregnancy outcomes and reducing disparities, we got to start taking care of women, not only during those 9 months of pregnancy, but before pregnancy, between pregnancy, beyond pregnancy, and indeed across their entire life course. Now, this may sound like a no-brainer now, but 20 years ago, calling out prenatal care as doing too little, too late was still considered a heresy. But fortunately, a growing body of scientific evidence that's accumulated over the past 20 years have really kind of proven this right, both in terms of the body of evidence supporting early programming, or now collectively known as developmental origins of health and disease, which posits that experiences in early life can influence your health and functions, including your reproductive health and functions for life, as well as the body of evidence supporting the cumulative pathways model, which posits that chronic stress across the life course, and this could be stress from childhood trauma, from poverty, from racism and so forth, can create wear and tear, or what's called allostatic load on your body's physiologic systems, which over time can take a physiologic toll on your health, including your reproductive health. And this may explain why prenatal care may be too little, too late, that to expect prenatal care in less than 9 months to reverse all the cumulative disadvantages and iniquities that have accumulated across the life course of girls and women may be expecting too much of prenatal care. And again, if we really want to improve pregnancy outcomes, if we really want to reduce disparities, we've got to start taking care of women, not only during pregnancy, but really across their life course, when they were just a baby inside their mother's womb, and an infant and a toddler and an adolescent and a young adult. And we got to make sure that we do more than just healthcare, right? We got to provide good education and nutrition and jobs and opportunity to assure the conditions in which girls and women can be healthy across their entire life course. So since this is a conference on global health, so let me then pivot to talking about global health. So what does the life course perspective tell us about improving global health? If there's anything that we learned from the prenatal experience, that perhaps we did too little too late to improve pregnancy outcomes, then what the life course theory tells us about improving global health is that we got to intervene earlier, we got to treat root causes, and then we got to go upstream. So first of all, intervening earlier, and perhaps much earlier than what we thought, what we had done previously. So for example, if we want to address the epidemic, the global epidemic of child obesity, we don't just start in childhood. That perhaps we need to start before birth. Or if we want to do something about promoting school readiness, we don't start with kindergarten or preschool. That perhaps we need to start in the first 1,000 days. Or if we want to do something about preventing neurodegenerative diseases and dementia, we don't start once cognitive loss has set in. We got to start much earlier, especially in light of recent evidence that's found that PET scan, that amyloid plaque formation actually began in people my age in the 50s. So we got to start much earlier than that. The problem that we still have today is we don't know how. What do you do with someone like me in my 50s in order to prevent the onset of neurodegenerative diseases in the next 2 or 3 decades? And that's where I think that's where the life course research really needs to go over the next few decades, is to really focus on pre-disease pathways, both in terms of mapping out early and long-term biological, behavioral, psychological, and social precursors to disease, and also identifying sensitive or critical windows along pre-disease pathways that are most amenable to interventions. My second point is about treating root causes rather than just treating symptoms. So let me take 2 current examples. The first is pandemic. And so how do we prevent future pandemics? Well, by preventing spillovers, right? When you look at all the major outbreaks over the last 20 years, and whether it's SARS or MERS or Ebola or COVID-19, these have all been caused by viral spillover when a virus jumped from an animal host to a human host. And with about 800,000 viral species capable of making that jump, lurking in the wild today, and with all the forces at play, both climate change and urbanization, globalization, deforestation, and wildlife trade, all fueling spillovers, all can bring in these viruses closer to, in closer contact with humans than ever before. It's really not a matter of if, it's a matter of when that next big pandemic is going to occur. So how do we prevent future pandemics? By treating root causes, right? And we can start by stopping the relentless human encroachment on natural habitats and the harvesting of wildlife. A second example I want to use is about institutionalized racism, which underlie much of the health disparities that we see here in the United States, as well as globally, right? And then the aftermath of the murder of George Floyd and the national global reckoning with institutionalized racism and all forms of violence, many of us are really rethinking about what's the role of healthcare and public health in addressing institutionalized racism. And over the last 20 years, I've been working with communities all across the United States, from Flint, Michigan, to Baltimore, Maryland, and I've been in many community meetings where it was really clear that the kind of health disparities that we see in maternal and child, the high maternal infant mortality rates, could really be traced to a lot of the structural problems, the structural racism that are manifest in differential access to healthcare, nutrition, housing, jobs, clean air, and water. And yet, because most of us who work in public health and in healthcare aren't trained to take down racist institutions, so we go back to what's convenient. So we talk about prenatal care, or talk about care coordination. But if we really want to do something about advancing health equity here in the United States and around the world, if we really want to do something about addressing root causes of poor health in the world, then we gotta be able to train that next generation of health professionals who are equipped with the knowledge, the tools, the skills to dismantle institutionalized racism in organizations, in healthcare systems, in public health systems, in their communities, and in their society and globally, right? And those are the things that we really, as institutions of higher education, as schools of public health, as schools of medical schools, schools for health professions, that we've got to do a lot better in preparing our students to dismantle institutionalized racism. And my last point is that if we're going to do all of that, we need to be able to go upstream. That if we're going to improve global health, we need to be able to go upstream to address a lot of the societal policy and political issues. So as much as we like to think that we can fix all global health problems with global health programs and services, tackling the root causes of some of our biggest problems will require social, political, and policy change. Much as the biggest gains in global health in the last 150 years have really come from regulation of food and environmental safety, passive child labor laws and women's suffrage, and overall improvement in educational attainment, economic opportunities, and social status of girls and women in our society and around the world. I think the biggest gains in global health in the coming decades will come from reversing global warming, cleaning up toxic waste sites, rebuilding our nation's infrastructure, protecting reproductive rights, reducing social inequality, and ensuring that the social conditions in which all children and families can be healthy and thriving. So let me just close with one of my favorite quotes and one of my favorite parables. This quote is from President John F. Kennedy, that all of this may sound like a lot of work, and all of this certainly will not be finished in the first 100 days, nor will it be finished in the first 1,000 days, or in the life of this administration, or even perhaps in our lifetime on this planet. But let us begin. And also, let me close with this parable that I grew up with about an old man who one day decided, with the help of his family, to remove this mountain that obstructs the way between his home and his field. And when mocked by a wise man about the futility of his effort, the old man simply replies that I myself may not succeed in moving the mountain, but my children and my grandchildren will keep at it. And one day the mountain will be moved. So let's start digging, let's move mountains. And you and I, we may not be able to succeed in moving the mountain, but our children and our grandchildren will continue the effort. And one day we will get to the world that we can achieve health equity for all. And ultimately, that's what the life course perspective is all about. Thank you very much.
Thank you very much, Dr. Liu, for that really inspiring and thought-provoking talk. So we have about a few minutes to have a Q&A session. The chat function has been very busy with lots and lots of questions. So what I'll do is I'll take pose a few questions from the audience to the speaker. The first one is for Professor Wu. One of the audience was asking whether you can explain a little more about how to optimize health service packages specifically for geriatric patients in Shanghai.
Okay, so what do we do for the patients that are in Shanghai, that especially when we do the disease management, that we try to give them the services continue. If we're talking about targeted as the population as a whole, and we started the prevention at first. And if we go to the prevention, then we collected all the risk factors and family histories and all these related environmental issues, that we give them evaluation. And then gradually that we try to using all these health information system to identify the high risk population. And then we focus on these population before they go to see a doctor. And we try to target it at, I think these targeted population is very important because they already on the risky to develop certain diseases. Then we targeted at these population. We try to early detection or the screening test for them to identify or early diagnosis of this population. And in the meantime, give them suitable intervention or suitable treatment. Once these patients develop as or diagnosis as a real patient, according to the diagnosis standardization, and we give them the treatment. But in the meantime, not only the treatment in the general hospital, but also we do health management in the community. All this information will disseminate to the health centers through our platform, unified information, we call health information platform, to follow them with long term according to their willingness. So that is the mainly that we do right now in Shanghai. Thank you.
Thank you, Professor Wu. I have one last question for Dr. Liu, and this is from a student who is saying that what could be done. There's a question that I was after. Okay, so the question is that there are many disparities between maternal mortality rates that are due to racial inequalities and structural inequalities. So are there any health-related interventions that can be done, or more policy, social justice changes are needed?
Yeah, that's a great question. You know, certainly not either or, right? You got to do both. There are certainly a lot of inequities within the health system. One of the things that we did in California was to promote these safety bundles. Basically, these are protocols and best practices that are evidence-based to improve the quality and safety of maternity care. And when we disseminated these safety bundles throughout hospitals in the United States, we actually were able to reduce maternal mortality in California by about 60% over a 6-year period. So there's definitely things that we can do within the medical system, right? That said, it's necessary, but not enough. That if we truly want to achieve equity, if we truly want to get to zero maternal mortality, that we got to do a lot more than just healthcare. And then it's about tackling those social determinants, tackling those root causes that can manifest in the air we breathe, the water we drink, the food we eat, and the social conditions which we live. That's going to be critically important in terms of advancing health equity here in the United States and around the world.
Thank you very much, both of you, for such an inspiring and eye-opening talk. So again, like to thank Dr. Wu from Fudan University and Dr. Liu from UC Berkeley. Now, please do stay around for the next session.